Today I shall be talking about acute osteomyelitis. As the name says, there is the inflammation of the bone which is for short duration and which ultimately leads to infection. This is the infection of the bone and its marrow by pyogenic microorganism. And on etiology, the common organism causing the acute osteomyelitis in newborn is anaerobic bacteroids, gram-negative, E. coli, Pseudomonas and Proteus, Salmonella, sickle cell anemia. If the children have sickle cell anemia and there is attack of typhoid fever, then Salmonella causes the acute osteomyelitis. In children, Staphylococcus aureus, Haemophilus influenza, Streptococcus pneumoniae and Streptococcus pyogenes. In adults, Staphylococcus aureus, Pseudomonas aeruginosa in IV drug users. So overall, the most common organism in all age groups is Staphylococcus aureus. And the common sites where acute osteomyelitis occurs is it most commonly occurs in the distal femur and then upper tibia, upper femur and upper humerus. It most commonly occurs in the metaphysis because as in metaphysis there is the cancellous bone which is loosely packed and it is more vascular. And when there is injury, there is increase in the blood and the blood acts as the culture media for the microorganisms. And the blood vessels of metaphysis is in hairpin loop where there is the sluggish blood flow and the microorganisms can accumulate here and can cause infection. And in metaphysis there is ineffective reticuloendothelial system. On pathogenesis, there is hematogenous spread in the children from 2 to 6 years of the age and the infection starts in the metaphysis and the host bone initiates inflammatory reaction in response to bacteria and there will be bone destruction and production of an inflammatory exudates and dead cells pause. Infection starts in metaphysis as in metaphysis there is hairpin loop and there is stagnation of the blood flow and the microorganism accumulate there. And the clinical feature on infants, there will be failure to thrive. The infant will be drowsy and there will be irritable child. And in children, there is recent history of infection, septic toe, boil and sore throat. From here, hematogenous spread will occur and there will be acute onset of pain and swelling. There may be systemic features like fever, malaise and increased pulse. And there is acute tenderness in the joint. And there is restricted movement and the patient will be refusal to bear weight. On early examination, the child will be febrile and dehydrated and there will be swelling and other classical features of inflammation localized to the metaphysis which can be rubor, calor, dolor and loss of the function. On late examination, there may be abscess formation and swelling of the adjacent joints. On investigation, on X-ray, we will see loss of soft tissue plane after 24 hours. This is the earliest changes we can see. When the abscess is formed, the soft tissue plane will be lost. And there will be periosteal reaction elevation which appears after 7 days of infection. Suppose this is the microorganism and the bone formation will occur and try to control the infection and when the microorganism is virulent and the host immune system is compromised, then there will be inflammation. On lab finding, in complete blood count, we can see the increase in TLC, total leukocyte count. In differential leukocyte, there will be increase in neutrophil as this is acute inflammation, increase in ESR and increase in CRP. MRI is the investigation of choice as the small abscess can also be appreciated in the MRI. Culture and sensitivity is the gold standard. We do culture for the microorganism and antibiotic sensitivity is tested. For the treatment, within 48 hours of onset of symptoms, rest is done by splint and the traction and antibiotics is given. And for children up to 6 years of the age, IV flucloxacillin plus cefotaxime, which is the third generation cephalosporin, is given. And for older children and adult, flucloxacillin and fusaric acid is given. And if the child has sickle cell disease, then ciprofloxacin can be added. And the duration of the treatment is we give IV till ESR and CRP and WBC becomes normal, which is usually up to 2 weeks, and oral antibiotics for 4 weeks. After 48 hours onset of the symptoms, surgical exploration and drainage of the pus is the mainstay of the treatment, and we can make drill hole at metaphysis and take swab for the culture and sensitivity, and the wound is closed over a sterile suction drain, and the rest and hydration continued, and antibiotics for 6 weeks. On complication, general complication, there will be septicemia, pyemia and meningitis. On local complication, if there is acute inadequate treatment or late presentation, chronic osteomyelitis can occur, and acute pyogenic arthritis, where the metaphysis involves the interarticular joint in infants, and the pathological fracture can occur as the bone is already become weak by the disease. And in growth phase disturbances, there is complete or partial cessation of the growth, and metastatic infection, the infection can spread to the other bones. This is all about acute osteomyelitis. Thank you.